Have you noticed changes that have come up during perimenopause or in your 40s and beyond? Things like acne that you haven't had for decades, or hair growth on your upper lip or chin, or in other places that used to not be so bad and now is something you have to deal with every day. There are so many things that are affected by estrogen and testosterone and progesterone, and the skin is our largest organ, so of course it's going to be affected. Tune in today to hear about how it's affected during perimenopause and menopause from an expert dermatologist. Dr. Mauskar is an associate professor in the Department of Dermatology and the Department of OB-GYN at UT Southwestern Medical Center. Her clinical practice is focused on women's health dermatology, addressing changes in skin and vulvar health that occur throughout different stages of life, which is why I have her on today to speak about perimenopause. She cares for patients with everything from acute rashes to acne. However, she is an expert in treating patients with vulvar dermatoses. She's the founder and the director of the Vulvar Health Program at UT Southwestern and is an expert in her own right. So excited to have her on here today. All right, so as I mentioned, Dr. Melissa Mauskar is a good friend, but more importantly, an expert in dermatology. And she's the first person who came to mind when I thought of, okay, we're going to talk about skin and how perimenopause and menopause affects skin. What do we need to know? So Dr. Mauskar, thank you so much for being here. What do we need to know about skin in perimenopause and menopause?
I'll say first off, perimenopause affects all parts of your skin, from facial aging to dryness to your hair, and even flaring of other conditions that you may have had at different points in your life. So it really, as the largest organ of the body, the skin really has a lot of manifestations of perimenopause. And I think we see that most often in kind of facial changes. And so I'll say that it's really interesting. In the 90s, before the WHI study came out, there were so many studies on skin and women on both topical and systemic estrogen replacement.
Oh, really?
Yeah, it's really interesting.
I took stuff as like brand new for being used on.
No. Yeah, this has been going on for decades. Yes, topical estrogens have been getting a lot of buzz lately, but really the first studies came out in the early 90s, like 1994 and 1996. And so these researchers looked at topical estrogen, and they actually used 1 gram, which is a ton, on patients' face and neck, and followed them for a 6-month period. And there was actually improvement in fine lines and wrinkles that they noticed. And actually so many different researchers looked at dermis thickness after applying topical estrogen. They did a bunch of biopsies and found that you can have up to a 33% increase in dermal thickness. Yes. And especially, we've got the epidermis, which deals with a lot of that moisture loss, which that's the top layer of the skin. And then the dermis is where kind of the collagen lives, and a lot of other glycosaminoglycans, all these agents that work together to pull in water. And so I made an interesting post about that a couple of months ago, because I feel like there's all these companies looking at different forms of topical estrogen, but we really need to do, and again, a lot of them have been done in the 90s. A long time ago.
And that's also when they were using Premarin, right? So it was like...
Yes, some of them were Premarin, and the horse urine. I tell all my patients, I was like, okay, I see that you're on Premarin. Did you know that's conjugated horse urine? And we've got things that are cheaper now, $13. It's so much better. But they, again, they did a lot of those studies. But what I want to look at is the topical retinoids compared to topical estrogens. Because we know in dermatology that retinoids help with skin turnover and everything. But finding funding for studies like that is hard because, it's considered cosmetic.
Oh, but that would be so cool. I would gladly be a participant in your study. I think it is amazing. I mean, right, there is the aging. Like I look back at my hospital badge or my profile from 5 years ago, and then I'm like, oh yeah, I can see the changes, but I'm like, what's aging and what's hormonal fluctuation? Do you have a good way of like explaining to people the difference between the two, or is it really all the same?
I think it's probably really tied together, but thinking about when patients like transition into menopause, I think it's less chronological age and more depending on like your hormonal status. So I do think that patients that go through menopause later and therefore perimenopause later will have longer stores of estrogen, But again, I think all of these changes are something that you should talk to your doctor about, because there are things we can do to prevent them. And What I'm interested in over the next couple of years is the preventative strategies. Should we start doing
Yeah.
things like topical estrogen when you're
Yeah.
going through perimenopause
Exactly.
for your skin? Or I don't know for your patients, if you recommend that they start low dose estrogen in perimenopause. I think that's all those conversations that we need to have and dive deeper into.
Yeah, I recommend it for a lot of people, and it's individualized, but I do recommend it for a lot of young people, younger people in perimenopause, because I do think there's probably a lot of prevention that we're not aware of, and if they're starting to have some symptoms already. So I'd almost think like skin is the same. If you start to see some
Yeah.
signs of change already, then probably there's some benefit. But you're right, we don't really know and like how to compare it to everything else. We're still on the new frontier for all of that, even though that research started in the 90s, which I didn't know until today.
Yeah. And I will say that there was another study that looked at women that were on systemic estrogen. And when you start systemic estrogen earlier, we're talking about skin here, but when you start it a little bit earlier, it's thought to decrease the degradation of collagen compared to if you start it later, that it may help build it up. So in theory, shouldn't we do both of those things?
Yeah,
I think that we'd want both of those, to sustain our best healthy self.
Yeah, exactly. That's so interesting. Okay, talk to me about hair, because a lot of my patients struggle with hair changes, hair loss, hair thinning, and that's part of perimenopause and menopause too, right?
Yes. And I will say that over time, a lot of women have thinning of the scalp midline. So that's kind of where things start. You have a wider part midline. But there are a lot of estrogen receptors in the scalp, and a lot of patients notice those changes, throughout time. Right now, hair is also having just a huge surge with different topical or oral medicines that you can take to supplement your hair growth. Oral minoxidil is kind of the new pill of the moment. Topical minoxidil or Rogaine been around for a really long time as well. I will say between those two things, oral minoxidil grows hair everywhere.
Wow.
And there was a nice study that compared topical efficacy compared to oral minoxidil.
So if you just put it where you want it compared to just taking it orally.
And I tell patients, and if you put it on the back of your hand, it will grow hair there. It's really good at growing hair. So you have to be careful. Oh, no, it was actually like very serendipitous. It's a blood pressure medication. And so they noticed in that study that patients were having more full hair.
That is so cool.
It's really fascinating. For dermatology now, we typically recommend lower dose oral minoxidil. So it's a 2.5 milligram pill. And depending on your situation, because it can cause lower blood pressure, you can do a half a pill or a fourth a pill. There's alternate day dosings you can do if you're starting to get hirsutism or more hair growth other places, but just some things to look out for.
Okay. Otherwise, you could just get the topical and directly apply it to the scalp. Yeah. And the hair has a long life cycle, right? I usually warn my patients, like whatever you're going to use, and even if estrogen might help to stabilize your hair follicles, which is what I think. I mean, I'm not a dermatologist. It's like my very cursory knowledge.
No, it's great.
But like I usually tell them that they're not going to necessarily see the full effects until 6 months later. Is that true?
Exactly true.
Okay.
And what's interesting with the topical minoxidil is when you first start using it, it actually helps link up the hair cycles. Okay. And so you may get more shedding when you initially start it, which freaks a lot of people out because they're like, I'm supposed to use this for hair growth. But that's actually a good sign. And so often when patients have that initial shedding, we know that they're going to have a good benefit from the topical minoxidil.
So interesting. I've had patients who've had hair loss when they were starting hormone therapy, which I was not expecting whatsoever. I mean, testosterone is separate. Like we could talk about that too, but just estrogen, progesterone, hormone therapy. And I wonder if that is similar or if that was just a weird side effect. But regardless, for, people who've experienced that, I can understand why they may not want to go through that if they're already having some shedding or worried about the hair loss.
Yeah, I will say that everyone notices that during pregnancy, they have very long, full hair. And that's because, our estrogen is highest during pregnancy. So I think as the estrogen starts getting lower, starting in perimenopause, that's when you notice those changes. I've had some patients come in and they're on topical testosterone, but oral spironolactone to protect their hair. Because a lot of patients will have hair loss when they're on testosterone supplementation. Yes. So, I mean, my thought is, could there be other ways that we look at things instead of giving you one thing and then So minoxidil, I feel like, is a nice way
I
to
mean,
get
I
around it.
I tell patients who have hair loss, like testosterone is contraindicated for you because it's only going to make things worse. And if you add spironolactone, then you're going to decrease their libido.
Exactly.
Also,
It's like,
I
okay,
usually
let's
say like,
think
let's
about
not go down that road.
doctor, good doctor.
No, thank you. But I mean, it's also because people see me for sex issues like sexual function too. So maybe if you really need your hair and you're not so worried about your libido, I don't know. But it's so interesting. And I want to ask you because you mentioned, the different medications and things that are out there that are coming out too, but they also see so much of like supplements that are out there and collagen, biotin, all of these different things to try to help your skin and your hair. And is there any worth behind any of them? Like, what is the deal? Because I see them even like at the grocery store being added to a soft drink or whatever. And I'm like, I don't know if I need that much collagen.
Yeah, I will say that we could have a whole hour-long conversation on supplements, and I find it completely fascinating. I always tell my patients, let's get your supplements from your food. So things I love for skin health and hair health are, fermented foods like kimchi or kefir. We also like just supplementation wise. I mean, I do think the vitamin C serums work really well. If you're going to do protein, again, getting that from your food, not whey protein, because whey can really flare acne and other inflammatory skin conditions. And so many diet or protein supplements. I went down the aisle, at a bulk store that sells things in bulk, and I was just amazed at the amount of whey protein supplements that they're selling to people.
Yeah.
But specifically talking about collagen. So the last time I kind of dove into things, and again, this is getting so much hype on social media,
Yeah.
but there's really not a study that I am familiar with that shows that ingested collagen can be broken down and then make it to your skin. I think that there's several meta-analyses that have come out recently, and those individual components may be different. I think bone health is different. But really, when we're thinking about collagen, I don't know how much is really going to make it to people's skin. And again, putting it in coffee now or whatever else people add collagen to is interesting. Things that you can put on your skin to like help hydrate your dermis to make it more full, I think is
something to that
conversation.
Okay.
No fountain of youth, I feel like, in a supplement so far.
Unfortunately, yeah.
but the biotin's another really interesting thought when you think about hair, because Nutrafol actually has like thousands more percent of biotin than you will need to help with your hair growth. And when you take excess biotin, it actually can falsely lower your like cardiac enzymes and also mess with your thyroid enzymes. So much that like the CDC put out a warning about ingesting biotin because a guy actually had a heart attack, but was found to have normal cardiac enzymes because he was taking too much biotin. So I think in moderation, great, like vitamins, great, but may not want to overdo it.
Yeah, exactly. And if you can get anything from your diet, that makes way more sense.
Way more sense.
That's so interesting. Okay, so what about acne? Because I hear my patients talk about acne coming out in perimenopause and menopause, and they're like, what in the world? Is that something that's really associated with perimenopause and menopause?
Yes. I think hormonal acne is really a heavy offender in this age range, mid-30s.
That's just cruel.
It is. And especially, honestly, if you escaped it during teenage years, I find out it comes out more in like the perimenopause years. So you can't get away from it. But spironolactone works incredibly well. And so that's, an oral pill that we take. As we mentioned earlier, it also can help grow your hair. So there's a two-for benefit there, but it really helps with hormonal acne. The side effects of it can cause leg cramping, sometimes some breast tenderness or irregular spotting in periods. But I haven't had patients that have wanted to go off of that because they haven't been as bad as the benefit that they see from it for their acne.
That makes sense. Yeah, there's so many interesting things. The other thing I wanted to bring up is sort of the autoimmune conditions. I mean, I think you and I have talked about the vulva a lot and the vulvar dermatoses. And maybe I'll just give you a hypothetical patient example. A woman came to see me and has a history of lichen planus on her scalp, lichen planus affecting her face. And she's coming in to see me because she's having burning and itching on her perineum and vulva and can't figure out what's going on. And I'm like, of course it's lichen planus. Like, I can tell you even before examining you, it's probably lichen planus. And, she had also been told that this was probably coming out more during menopause. And that's what we tell people too, right? We see low estrogen states with some of these vulvar dermatoses, but sometimes people are not associating them with other dermatoses or dermatological conditions in the rest of their body. But that is a thing, right? That it happens after or during or after perimenopause and menopause.
Yeah, I think it's the interplay between having lower estrogen, more water, transepidermal water loss. So you get a lot more symptoms with even common conditions. So things like atopic dermatitis, psoriasis, lichen planus, a lot of these things can become more symptomatic or actually, manifest more during that perimenopause, menopause period. I think that, our skin is a really dynamic, interesting organ, and it actually creates its own hormones too, which is something that one of my colleagues studies a lot. But it is really interesting. And especially with vulvar conditions, I think as people develop dryness or, symptoms of genitourinary syndrome of menopause, they may blame it on one skin condition and it's really the other, or it's the interaction of both of them. So.
Right. And I think that's a good point. Maybe it's a good public service announcement that if you are perimenopausal or menopausal and you have a vulvar dermatosis like lichen sclerosis, lichen planus, I don't know if psoriasis is quite the same or not, but I would think so. Really anything with dryness, then you may want to talk to your healthcare professional about being on vaginal estrogen as well. That's something, as long as the patient doesn't have any contraindications, and there are very few contraindications for vaginal estrogen, I try to get my patients on vaginal estrogen along with whatever we're doing for the treatment for their vulva.
100%. And as I mentioned, that some of those early 90s studies showed that when just applying topical estrogen 3 times a week, this one group in 94 did on the buttocks, and they did it under occlusion, but then they took biopsies and found that you had an increase in dermal thickness after just 3 times a week and doing that.
So even if maybe, I wonder if people are having facial lichen planus, they should be using topical estrogen maybe too.
I mean, what's interesting about our face is it can be very hormonally sensitive. So things like melasma that happen more in pregnancy, if we're using topical estrogen, some of those 1990 studies found that up to 11% of women develop melasma.
That's a good point. So, melasma is this masking, a mask kind of distribution. You probably can explain it better than, but I don't always saw it in our pregnant patients, right?
Yeah, it's that hyperpigmented, brown coloration. You can also have increased blood vessels. So I feel I think it is important not to just go home and smother all this on your face, but definitely talk to a dermatologist or your doctor about, if that would be a good something for you to do until we kind of update our studies a little bit.
Yeah, you're right, because sometimes high levels can cause other problems. Can we talk a little bit about testosterone too? Because we have a lot of women in perimenopause and menopause who are on testosterone for low libido. And what would they expect to see changing with their hair or their face or anything? What should they be on the lookout for?
It's funny. I don't know about you, but I can always tell patients that are on too much testosterone. They come in and they have much lower voices. They have very sparse hair, especially here. They're getting very pointed features. Sometimes they can even be a little bit more tan. I do think that your skin and your vulva can definitely, skin on your arms, but other places too, can dry out with too much testosterone. And so I definitely think that it can impact your skin. You can develop itching or picking because of that dry skin. So you have to have that balance of, yes, a lot of patients do need it for libido, but you can go the other way and develop a lot more of these.
Even for libido, it's only recommended to be at premenopausal ranges. So not the whopping doses that people are getting from testosterone pellets. Just another public service announcement.
Yes, please. We don't need many penises out there.
Yeah. And all the other things like hair growth, acne, oily skin, right? That's the other stuff I usually tell people to look out for. Oh, but that's interesting. I feel I don't see a lot of patients who are on pellets here, but that description makes sense.
Oh, we have them, a lot of them, unfortunately. And again, it's different, I think, than, someone that needs a little bit of topical testosterone or they're working with our provider monitoring those levels. I think pellets can be really dangerous, especially when people start getting addicted to pellets and then they're coming in more frequently or just getting subcutaneous injections too, which is what I had some recent patients getting also.
Wow. Anything else that people should be on the lookout for at this time of their life? Is there anything else that they should be keeping in mind? Okay, this is not just perimenopause. This is something else that I need to see a dermatologist about.
Yeah, I think a lot of the things we talked about can be applied just to regular, everyday skin changes, dry skin, hand eczema, hair shedding or loss. But a lot of times other conditions can affect those too. Like if you have vessels on your hands or you're getting a lot of hand breakdown, that's probably not just dryness related to perimenopause. You may have hand dermatitis, eczema, contact dermatitis. I think that a lot of times we see, fine changes. I know you wrote this lovely poem that I love about why I wish my vulva was my face, which I still talk about all the time. We know that, over time we do lose our dermal fullness and you do get some sagging, but there are some conditions where your mouth changes and you actually have narrow opening to your mouth or hardening of your skin that can be a sign of other autoimmune diseases. I think thyroid conditions also get misdiagnosed sometimes as perimenopause or the other way around.
Yeah. Okay. Well, thank you so much. This has been super helpful. And we would be remiss if we didn't say protect your skin.
Sunscreen too. I guess I almost forgot about sunscreen. I think I think sunscreen is one of the best things you can do no matter what age you're at. Definitely starting even before perimenopause, I think finding a good routine, find something that you like the way it feels and leaves your skin. And just after you brush your teeth in the morning, face, neck, hands, and arms. Because again, as you go through perimenopause and menopause, and then you get to 70s, 80s, 90s, the earlier you can have that really good sun protection routine, the better. We know all of these aging factors, multifactorial, right? It depends on your estrogen status, but also your cumulative sun exposure. I know everyone has seen patients that are in their 70s, 80s with the bruises on their arms from decreased dermal thickness. And so you can prevent that now in perimenopause by adding sunscreen, to your arms on a daily basis.
Oh my goodness. I have to admit, I do not put sunscreen on my arms and my hands on a regular basis. Unless I'm going out and going to be in the sun. That's a really good point. And I always think that hands are kind of like the secret to seeing what age a person is, right? We all know the person who looks like a decade younger than they actually are, or someone who's had a lot of plastic surgery. And you look at their hands and you're like, oh, actually. But if you start putting sunscreen on your hands, I have not been doing that. I'm going to start doing that. Awesome. Well, thank you so much for your time. I really appreciate it. And I know all of our listeners are so lucky to have your expertise here today.